Hi, I'm Jag Singh from Medscape Cardiology. I'm delighted to be here. I have with me Bill Abraham, who is a distinguished professor of medicine from Ohio State University. Along with that, he is one of the most world-renowned heart failure physicians that I know. We're going to be talking today about remote monitoring in heart failure, which I think is really a great topical interest. And Bill has done a lot of work in this arena. Bill, as an electrophysiologist, we have been doing remote monitoring for a while, but it's really focused in devices. Heart failure is a different ballgame completely. So can you kind of give us an idea what your practice for remote monitoring in the heart failure patient entails?
Yeah, well, first of all, Jag, it's a pleasure to join you, and thank you for the kind introduction. Look, we're behind in heart failure in remote monitoring of our patients, and I'm somewhat envious of the electrophysiologists. And certainly we've learned a lot from you, and we need to apply those learnings to the management of heart failure patients. Managing congestion in heart failure really is the key to keeping our heart failure patients well and keeping them out of the hospital. The problem is on a day-to-day basis, it's difficult to judge the degree of congestion that our patients have, particularly when they're at home. So in our practice, we're increasingly adopting emerging technologies that give us direct measurements of either intracardiac or pulmonary artery pressures, or at least give us some physiological measures that may be predictive of future heart failure events.
So Bill, these devices that we as electrophysiologists implant have many device diagnostic sensors in them. Can measure heart rate, can measure transthoracic impedance, can measure respiratory rate, heart sounds, all of those things. Some of them even offer the opportunity of integrating these signals to predict which patients might actually land up having heart failure. Where do you think that role lies in these device-based sensors vis-a-vis the standalone sensors like pulmonary artery pressure monitoring or direct left atrial pressure monitoring? Where do you think the field is going, and how do you correlate these two?
Yeah, so first of all, we should definitely leverage and take advantage of the information provided by cardiac implanted electronic devices like pacemakers and defibrillators. And in that regard, I'll just mention parenthetically, both primary prevention ICDs and CRT are underutilized in the management of heart failure patients. I would encourage the audience to follow guidelines and aggressively or more aggressively use those devices in their heart failure patients. But for those who have these devices, we can get an awful lot of information, which seems to be highly predictive of future heart failure events, such as a heart failure hospitalization. I think the limitation of those approaches to date has been that much of the information is not directly actionable. It predicts risk, it tells you who to worry about more and who to worry about less, but it doesn't necessarily enable day-to-day management changes. You don't necessarily know when to increase the dose of the diuretic, for example, or how much. And that's where I think the standalone implantable hemodynamic monitors play a big role. They give us an absolute measure of either left atrial or pulmonary artery pressure. And since we understand what those pressures mean, and since the values are absolute rather than relative values, they're actionable. So if, for example, the pulmonary diastolic pressure goes from something in the normal range to something that's elevated, we can simply implement an algorithm of increased diuretic use that will restore it to normal and avert a hospitalization. And that's now demonstrated to work in multiple randomized controlled and observational studies.
Do you feel that these measures from within devices and standalone are complementary information, or let me kind of rephrase that. Many patients don't have standalone devices, right? But they have these devices which give all these different parameters. Do you feel the construct of a remote monitoring pathway where you have clinicians who interact with the patients with this device-based data can really make a better decision than without having this data?
Yeah, absolutely. And I would describe a concept of using the totality of data. Right, we use clinical information, patients' report of changes in symptoms, for example. We can use data that comes from those implanted pacemaker and defibrillator type devices. And of course, in patients who have an implantable hemodynamic monitor, that may take some, sort of primacy in the decision making, but always decision making should be made on the totality of information that's available. So we really want to use it all. And while it seems on the surface to be complex, the algorithms that have been developed over the years for use of this information are really pretty straightforward.
No, absolutely. So on that note, it's a fairly complicated care pathway where you have this data that comes out, you have to find the clinician puts it together, has the interaction with the patient. Do you feel that with these implantable standalone devices, one, is there the possibility of a closed loop strategy where, the device can kind of help regulate the pressure itself, or inform the patient how they can manage their own disease? So this concept of self-management. I'd love to get your thoughts on that.
Yeah, I think the most sort of available approach to a closed loop system is to include the patient in that loop, and to implement a physician-directed patient self-management strategy, which is fully analogous to the management of diabetes. We have for many years used glucometers to inform patients of their blood glucose level, and under physician-prescribed guidelines, allowed our own patients to titrate their diabetes medications, most notably insulin. And so in that regard, one could provide, for example, measurements of left atrial pulmonary artery pressure directly to patients. And under physician prescribed guidelines, patients on a day-to-day basis can self-titrate their medications, particularly their diuretics, to restore or maintain normal pressures as a means to keep them well and out of the hospital. And in fact, as you well known, in a trial that you and I participated in together, we're part of the leadership of, called the laptop trial, preceded by the homeostasis pilot study, and then the laptop trial implemented this physician-directed patient self-management approach. And the preliminary data looks very good for this. We need more studies going forward.
It makes sense, the hemodynamics, suggesting the medications and translating into better clinical symptoms. Is there any data for its impact on clinical outcomes in terms of heart failure hospitalizations and mortality? Can you kind of bring us up to speed?
There is. First of all, in the homeostasis study, we demonstrated a marked reduction in heart failure hospitalizations using the physician-directed patient self-management approach, which resulted in most patients having left atrial pressures consistently in the target range, and was associated with a vanishingly small rate of recurrent heart failure hospitalization. That was a longitudinally controlled study, and the rates of heart failure hospitalization were quite high, prior to implementation of this approach. Laptop, which used a first generation left atrial pressure monitoring system, was stopped early because of some transseptal complications. But when one looks at the data, underpowered because of the early termination of that study, but there certainly are signals confirming that approach. There's now under development, still investigational, a batteryless wireless left atrial pressure system. Let's call that second generation technology for left atrial pressure monitoring, that is in the clinic, has undergone first in human and now ongoing pilot studies. There are a couple of publications out there. It is demonstrating similar promise, and we expect trials to start in the US maybe in the next 6 to 12 months, and ultimately a pivotal trial to further evaluate this approach.
Got it. Is this the VLAP study?
This is VLAP, yes.
Yeah, oh, that's awesome. That's awesome. We're really looking forward to that, because I think, again, it gives the patients eventually the power to, self-manage themselves. And I think for healthcare to remain sustainable, you really need to get patients to have some skin in the game, so that we can, I would say, enhance efficiency and reduce the burden on the clinician.
Absolutely. And the other thing I found, Jag, is that, patients get really engaged in this, right? They start to take control of their disease and they like it.
Absolutely, absolutely. So I'm going to try to end with one question. How come folks have not adopted remote monitoring as much as you and I have in our practices and think that it can make such a huge difference? What has been the biggest limitation on that front in terms of adoption?
Well, look, I'm a heart failure specialist, but I can be a bit, self-critical of the heart failure community, of our community, my community, which I think for many years has focused on drug therapies for the management of heart failure, and perhaps looked at device-based approaches as being more or less of a last resort in our patients. Device therapies are clearly underutilized. The heart failure guidelines, I don't think have kept up with the evidence. Like, let's take the CardioMEMS HF system, a pulmonary artery pressure measurement system, which enables PAP-guided heart failure therapy. There are now 3 randomized controlled trials, at least 3 prospective observational studies, and numerous retrospective analyses that all show exactly the same thing. Patients' quality of life is improved substantially with PAP-guided heart failure management. And there is, looking at the totality of the data, about a 35 to 40% reduction in recurrent heart failure hospitalizations. If this were a drug, it would have a class 1 indication in our heart failure guidelines.
There you go. Absolutely. And lastly, should this be a specialty-specific monitoring strategy, or should this be an integrated multidisciplinary effort between EP, heart failure, and the general cardiologist? What are your thoughts on that?
Yeah, I think it should be integrated and multidisciplinary. We heart failure specialists should leverage the infrastructure that the electrophysiologists have already developed for device-based monitoring. Certainly, the primary cardiologists involved in the care of these patients, needs to be kept in the loop as well. And the information systems for transfer of this data are really quite good now. So at least there are no technological barriers to implementing that multidisciplinary approaches. I think if there are any barriers, it just relates to developing the proper relationships to make it work.
Terrific. Well, Bill, thanks so much. This has been very illuminating. I think we recognize that there are a lot of benefits for remote monitoring of heart failure, clearly translates into better clinical outcomes. And as you ended, we really need to be working together across different platforms and different disciplines to ensure that our patients are getting the best possible care from a distance, safely, whenever they want it, whenever they need it, and for the right reasons. Thank you again for your time. Really appreciate it. Thanks again to our listeners for tuning in. This is Jag Singh from Medscape Cardiology. Thank you.